Sometimes we just want EM knowledge delivered fast.
Yeah, this is the Emergency Medicine Cases EM Quick Hits podcast.
And we're your hosts, Dr. Katie Lynn
and Dr. Anton Hellman. Let's go.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. In case you haven't heard yet, tickets for the next virtual EM Cases Summit just went on sale July 14th at emcasessummit.com. Please join us November 21st, 22nd, and 23rd for 3 days of the best EM Cases speakers from around the world, state-of-the-art procedural demonstrations, expert panel discussions, rural EM sessions, prize giveaways, simulations, and fully accredited CME. It's also a great opportunity to connect with emergency clinicians from around the globe. And if you've been enjoying EM Cases for free over the years, attending the EM Cases Summit is one of the best ways you can support our mission and help us continue producing free podcasts, blogs, videos, and educational resources. Hope to see you all there. Visit emcasessummit.com for all the details.
Hello, EM Cases listeners. This might just be the cheesiest title we've come up with yet for you. Welcome to the EM Cases series, or EMC². I'm your host for today, Dr. Katie Lynn. In this EMC² Quick Hits series, we're sharing real, high-yield cases with you to break them down and learn together. Patient details have been anonymized, but the cases, decisions, and outcomes are all very real. Today, I'm excited to welcome Dr. Amna Karabegovic to the podcast. Amna is an emergency physician at North York General Hospital in Toronto, Canada. She's also the current program director for Toronto's CCFP EM residency training program and former co-director and ongoing committee member for the renowned EM Update conference held in Toronto every spring. Amna, welcome to the podcast.
Thank you so much. Such an honor to be here.
Amna, you have a pediatric case for us today. I'm sure I'm not alone when I say that sick kids increase my cortisol levels. So set the scene for us. How did your pediatric patient initially present?
So I was working a regular emergency medicine shift when we got a dispatch from EMS that we have 5 minutes and they're bringing us a 5-year-old female child with altered level of consciousness and vomiting.
All right. So you have 5 minutes. How are you preparing your team before the patient arrives, and what's going through your mind at this stage?
So the first thing that went through my head is I need to get things ready. So thinking of 3 R's that I always have in my head. So get the room ready, get roles assigned, and get resources ready. So the first thing is making sure that we have readily available resuscitation area with all the equipment, getting my team collected. So making sure we have enough nurses, calling down the respiratory therapist. I'm lucky enough to work in the department where there is a second ED doc. So I called my colleague over. And then ensuring that all our resources, pediatric crash cart is there, and all the adjuncts that we may need to resuscitate appropriately this patient.
I love that approach to prepping your team for a high-stress case. Rooms, roles, and resources. Once your patient arrived, how did that case unfold?
So the patient was wheeled off into our resuscitation area. She was unresponsive. She vomited twice en route to the emergency department. She did not have any seizure activity. And upon arrival, her blood pressure was 100/54. Her heart rate was 78. Her rest rate was 30. She was setting 96%. And our EMS crew got her blood glucose level, which was 7.4. She was unresponsive. She was moaning. Her eyes were closed. She did withdraw to pain. So right off the bat, estimated to be GCS about 8.
So you've got, Amna, a pediatric patient with a pretty low GCS in this case and some concerning features. What was on your differential diagnosis at this point in time, and how did you prioritize those next management steps, the immediate ones that you're going to take next?
So I think the first thing that we did, I had a second emergency colleague with me. So I got him to speak with the family and get a little bit more history on what was going on. But in terms of differential, any patient with altered level of consciousness, be it pediatric or adult, I always think is a structural versus metabolic. So when we think of structural causes, what was in my mind? Did this child have a tumor? Was there an infection, encephalitis, meningitis? Was there bleed? Pediatric strokes are real in that patient population. So that was sort of structural causes. And then in terms of metabolic causes, right off the bat, we ensured this child is not hypoglycemia. So her blood sugar was normal. And then we started thinking through other things. Again, is she septic? Are there any other electrolyte abnormalities? But even before that, just looking at her vitals, did she have any vital abnormalities like hyper or hypothermia? She wasn't febrile. She wasn't cold. What was her blood pressure, her rest rate, her heart rate? So looking at those based on the vitals, kind of going through my differential, was there any abnormalities there? And we didn't initially. There really wasn't anything that stood out. Other things, could there be an overdose? Did she take anything? So my colleague was gathering that information. It became really clear that this was a healthy little girl who went to school earlier. She was completely fine. She's healthy, immunization's up to date. There was no trauma. So that was another thing. Was there a trauma at school? We were also thinking, could there be accidental trauma? And, mom said, no, she was at school. There was no injuries reported at school. She picked her up. She was fine. And then on the way home, she started complaining of headache and then vomited at home and had altered level of consciousness, which obviously prompted 911 call. So my differential became very narrowed down. This is probably something structural. We obviously got all the labs, all the blood work. We got 2 IVs. She was hooked up on the monitor. I did call my pediatric colleagues to come down. And my first priority was I need to get this child to CT head. She's still maintaining her airway. Her vitals are, somewhat stable. I want to get that CT.
It sounds like you made the decision pretty quickly to prioritize CT head here in this patient. I know that we often worry about ionizing radiation exposure when it comes to pediatric patients. And so I think just to double click on that idea that when you've got a critically ill patient in front of you, even if they're pediatric, CT is the most accessible imaging for most of us, certainly in Canada. And even with that radiation piece to it, still so important for us to be able to see what's going on inside the head to look for those structural emergencies. So we don't need to be afraid of using CT in the appropriate context, even for our pediatric patients. Did you give the patient anything pre-treatment wise going to CT scan, or did you send her and then worry about that later?
So when she arrived to the emergency department, we did give her a bolus of fluid because she was vomiting. We did pre-treat her with antiemetics. So she got a dose of Zofran, and we did give her a tiny dose of fentanyl.
Those are great empiric therapies that are going to be protective from a brain perspective, even before you know what your imaging is going to show. The use of antiemetics, you're hopefully going to prevent her from vomiting again and causing, resuscitation in the donut of truth. So I love that you did those things. And then what did her CT ultimately show?
So unfortunately, her CT showed extensive intracranial hemorrhage with hydrocephalus and possible cerebral edema. And it was suspected to be in the region of the right lateral ventricle, either posterior horn or trigone. It was either intraventricular versus periventricular blood. So the radiologist did note that possible etiologies could be either AVM, subependymal cavernous malformation, and intraventricular tumor. Her CT was quite impressive.
And that is a pretty terrifying CT head report to receive for a pediatric patient. Once your patient returned to the emerge from the CT scan, what did she look like and what were your next steps now that you have that imaging diagnosis?
So once she returned, again, she went straight on the monitors. We got a new set of vitals. And one of the things that we've noticed is that her heart rate has gone from initial 70s down to 50s. She was still GCS of 8. Her oxygen saturation was still adequate and the blood pressure was fine, but it was the bradycardia that made us a bit worried that she's developing increased intracranial pressure.
Mm-hmm. And so let's talk about that raised intracranial pressure. What were some of your initial steps for management?
So I think simple things that we did, just elevate that head of bed, and then just ensuring that, we maintain that strict normothermia, that she's not getting overly hot or cold, that we maintain euvolemia. So make sure that she's volume resuscitated, recheck her blood glucose, make sure that she's not getting hypoglycemic. She was given isotonic fluid. We ensured, she was put on oxygen just to maintain O2 sat above 95%. And giving her adequate analgesia as well, just to prevent exacerbation of that elevation in the cerebral perfusion pressure. And we knew that at this point, we got to secure the airway. So just going through our priorities were ABCs, adequate ventilation, making sure that we avoid any sudden drops in MAP and make sure she's euvolemic. So those were kind of initial things as we were setting up to secure her airway. So at this point, I was calling for hypertonic saline, and this was a huge learning point for me when we were advised that we should be giving hypertonic saline as opposed to mannitol. And part of the reason is that hypertonic saline doesn't have as many side effects as mannitol, and one of them, the biggest one, being osmotic diuresis. So increased risk of osmotic diuresis, which further increases risk of hypovolemia, which then further exacerbates the intracranial pressure. So it leads to dehydration and electrolyte imbalances. I also want to remind the listeners that if you don't have hypertonic saline, you can use mannitol. It's just important to have that in your back pocket, that you need to monitor the urine output as well as the electrolytes very frequently.
Absolutely. And so to reiterate, unlike in adult patients, where most of the guidelines in the literature would say either your hypertonic saline or your mannitol are both equally reasonable options, the 2019 Brain Trauma Foundation guidelines specifically recommends strongly that for pediatric patients, hypertonic saline is your first line for ICP lowering hyperosmolar therapy. And this was reiterated in a couple of different subsequent studies, including a 2020 RCT, which actually showed that you get better ICP control with hypertonic saline compared to mannitol as well. And then all of those additional side effects that Amna mentioned too, in terms of fluid shifts from osmotic diuresis. So again, mannitol is not contraindicated in pediatric patients, especially if you don't have access to hypertonic saline. But if you do have hypertonic saline available to you, that is first line in pediatric patients, especially the younger kids under 2 years old. Did you have any quick rules of thumb for dosing, Amna, with your hypertonic saline?
So very easy to dose. So it's 3% hypertonic saline. So it's 3 cc's per kilo IV. So it's very easy to remember. 3%, 3 cc per kilo.
3%, 3 cc's per kilo. I love it. Let's talk about your airway considerations next. Walk me through your decision-making when it came to approaching this airway in your pediatric patient with a bad head.
So at this point, we did make a decision that this should be a first attempt success and we should get the most qualified individual to do this. So we did call anesthesia to come down and intubate the patient. And I think one of the things to think about when we're intubating these pediatric neurocritical care patients is that their reflex to endotracheal intubation is much more significant than in an adult population. So it's the parasympathetic response, which is mediated by the vagus nerve that can produce sinus arrest or bradycardia. And we know that video laryngoscopy has a much higher first attempt success rate than direct. So using video mitigates some of that risk. And then ensuring the adequate pre-oxygenation in this case is huge, because we know that if they're hypoxic, that will also lead to reflex bradycardia as well. So in terms of pre-intubation optimization, so just ensuring adequate pre-oxygenation, making sure that your ICP pre-treatment is done. So head of bed, your 3% hypertonic saline, and we did also use a bit of fentanyl as a pre-treatment for the intubation.
Coming back to that point you mentioned about bradycardia with intubation and laryngoscopy in pediatric patients, historically they've talked about the use of atropine as an adjunctive treatment in airway capture for pediatrics. But what's your thoughts on atropine utilization? Was that discussed at all in this case?
So we did discuss it, and we were told to hold off for pre-treatment with atropine. So the use of atropine as a pre-medication for pediatric patient is quite controversial. Bradycardia is common during pediatric intubation, and the most commonly results from associated hypoxemia. And so atropine is not actually predicted to prevent hypoxia-induced bradycardia. So really the premise for atropine use as a pre-medication is to attenuate that high vagal tone that's common in young infants, which is triggered by the placement of the laryngoscope. However, you should have it on hand along with epi, and it's definitely still recommended for kids less than 1 year of age. It can be considered in kids less than 5 years of age, but after that, really, there's no evidence that it prevents bradycardia during pediatric intubation.
There you have it, folks. So atropine, not routinely needed for RSI, even in pediatric patients. Definitely want to have it on hand for your pediatric intubations, especially if they're under 1 year old. But really the biggest bang for your buck is adequately pre-oxygenating that patient and preventing hypoxia, which exacerbates that bradycardic reaction. Now that we've talked about ICP management and neurocritical airway management for this pediatric patient, I want to talk a bit about intracranial hemorrhage or ICH considerations, because in adults, spontaneous ICH is most commonly caused by uncontrolled hypertension, with bleeds that typically occur deep in the brain, classically the basal ganglia or your central cerebellum. But it's really quite different in pediatric populations where anatomic vascular abnormalities are actually the most common cause of spontaneous ICH. Specifically, like in this case, arteriovenous malformations or AVMs are the most common cause, with a 6% per year hemorrhage risk if they are present, and a 25% mortality rate per hemorrhage event. That's 1 in every 4 hemorrhage events results in death. Other pediatric non-traumatic ICH causes include cavernous malformations, intracranial aneurysms, intracranial tumors, and unrecognized coagulopathies. All right, Amna, so back to your case. Did you receive any advice on blood pressure targets while managing this pediatric ICH?
It's interesting that there's really no guidelines for blood pressure management in pediatric neurocritically ill patients. We were told that we should maintain it at about 95th percentile for age, sex, height, and weight, and just to avoid hypotension in general. So really, bottom line is that there's no guidelines.
Yeah. No good guidelines, no good literature. We just don't have a lot of evidence here. But as you mentioned, it comes back to avoiding hypotension because we know that that is bad for a sick brain. And in adult spontaneous intracranial hemorrhage cases, we often aim to lower that systolic blood pressure to about the 140 to 160 millimeters of mercury range within the first hour. But that evidence is really lacking in pediatric patients. But our specialists in general here as well would advise systolic blood pressure less than about the 95th percentile for age. But I just want to take a moment to remind listeners to look up your pediatric vital signs here. Amna, can you tell us what happened with your patient ultimately?
So she was intubated, luckily, on the first attempt with fentanyl, ketamine, and rocuronium. We gave her 3% hypertonic saline. We started her on morphine infusion. So that was another learning pearl for me. So for post-intubation sedation in pediatric patients, morphine is indicated. The tertiary care transport team took her to the tertiary care center. And she ended up having that same day left external ventricular drain placed. Next day, she underwent CT angiogram and embolization of the AVM. She continued to clinically improve over the next few weeks. Her drain was removed. She started physio and occupational therapy during her stay at the tertiary care academic center. And eventually, she was transferred to rehab, where she spent about a month. And she is at home doing very well and almost back to her baseline neurological status. So really good outcome.
That's an amazing outcome.
Really good
Amna.
outcome.
And I think that really highlights the importance of, even when patients come in looking so sick, sometimes the interventions that we render in the early stages can make a huge difference down the road. And neuroprognostication is ever so challenging, and particularly with young neuroplastic pediatric brains. So if you're reflecting on this case, what do you think contributed to the success here, Amna?
So this case to me highlights how teamwork in emergency department can make enormous impact on the outcome. When I first saw that CT, my heart sunk. I just felt so bad for this family. This is a completely normal child, well-adjusted, went to school, and now she's got a brain full of blood. And I think the supportive team, the pediatrician that came down and we worked so well together, and the whole team, the communication was excellent. The communication with the pediatric ICU. And I just think we were all just listening to each other, hearing each other out, and just sort of bouncing ideas. It was truly the teamwork, the communication that led to an incredible outcome. And I think at the end of the day, emergency medicine is a team sport, and this case really, really outlines that.
I 100% agree. Let's recap some of the big take-homes from this case as we close off this segment. First, that the crashing neuroexam is the same in pediatric patients as it is in adult patients: GCS, eyes, and motor. Don't stress calculating the specific GCS value, or potentially even consider using a simplified tool like the AVPU EVPU scale as a surrogate, especially in your pediatric patients if you need to. It has been shown to correlate with broad GCS categories. The red flag clues for raised ICP here and brain herniation are the same in pediatric patients as they are for adults: that dropping level of consciousness, increasing confusion or focal deficits, vomiting, your Cushing's triad of bradycardia, hypertension for age, and irregular respirations. Remember that hypertonic saline is the preferred hyperosmolar therapy in pediatric patients, and think 3% saline at 3 cc's per kilo for an easy way to remember your dosing. If you don't have hypertonic saline available, you can also use mannitol, but monitor your patient for electrolytes and urine output very carefully because they can get an osmotic diuresis. Atropine is not routinely recommended or required for pediatric intubation, but if your patient is already bradycardic going into airway capture, you may consider it as a pre-treatment. You want to have it on hand, especially for younger patients under the age of 1 year old, as they are at increased risk for reflex bradycardia from laryngeal stimulation. But the biggest bang for your buck is to prevent hypoxia in the lead up and preparation phases towards airway capture. And finally, get your consultants on the line early. Timing here is critical, and it takes a coordinated team to provide definitive care in these cases. Thank you so much for sharing this incredible case with us today. I think it really highlights the importance of that team aspect of emergency medicine and the real impact that you can have on patients in their moments of crisis. Thanks so much for joining us today.
Thank you, Katie.
You know which diagnosis always gets me worried a little bit more than usual in the ED? That is pulmonary hypertension. It's like a teeter-totter. Little bit too much volume, they crash. Little too little volume, they crash. The hemodynamics are extremely delicate, and sometimes they need to be intubated, but I know that intubation in these patients carries a super high mortality rate. You know, your aim in these patients is to maximize contractility while minimizing RV afterload, and that's not easy. In Mike Mish's excellent Crit Cases blog on the EM-Cases website, he covers these issues beautifully. And what we really want to do in these patients is get fast pulmonary vasodilatation, which historically requires fancy drugs that I can't even remember their names. They're only used in the ICU, that they don't let us use in the ED. But we have alternatives, and that's now what Swami's going to concentrate on in this quick hit.
Pulmonary hypertension is an extremely challenging diagnosis to make. Really, that's its own podcast. What we're going to focus on is treatment, because treatment is wrought with challenges as well. The most common places that we see this in the emergency department is patients with acute pulmonary embolism resulting in right heart strain and pulmonary hypertension. And of course, we also see patients with primary pulmonary hypertension who are presenting with acute worsening. The first thing that we want to address is hypercarbia and hypoxemia, because both of these are going to worsen pulmonary hypertension. Of course, we know one of the easy ways to fix both of those parameters is by intubating the patient, but we want to avoid intubation at all costs. Switching these patients from negative to positive pressure ventilation can drop pulmonary venous return. It can increase RV afterload, which is going to worsen RV stress and failure, and the patient's going to decompensate pretty rapidly. Non-invasive with bilevel is actually a good step. Even though bilevel does produce positive pressure, the patient still has to initiate breaths. There's still going to be that negative pressure ventilation going on, so it's not going to result in the same acute worsening that we see with intubation and mechanical ventilation. Of course, that being said, it's all a trade-off, just like everything in medicine. Bilevel can drop your CO2, it can increase your oxygenation. That's going to improve pulmonary hypertension and lead to improved RV performance. But you are providing positive pressure, and that can worsen the patient, although I think that the benefits of bilevel far outweigh the risks. High flow nasal cannula is reasonable, though it's not really going to help with that hypercarbia. Under some circumstances, fixing hypercarbia, fixing hypoxemia can be enough to stabilize the patient, but typically we're going to need to think about direct pulmonary vasodilators. The classic gold standard agent in acute presentations is inhaled nitric oxide that can drop pulmonary pressure rapidly, but it's expensive, it's not always available, and depending on where you work, it could take hours to get it going. I've worked in a number of quaternary care centers where nitric oxide is technically available, but I've never been able to get it to the bedside of a patient who needed it in the emergency department. Inhaled epoprostenol is another great option, but again, it's not always available in the emergency department, and delays can occur in getting this to the bedside from pharmacy, delays in getting it administered, and time is really critical in these patients. Because of all of these issues with nitric oxide and with epoprostenol, inhaled nitroglycerin is a great option. Inhaled nitroglycerin is rapidly converted to nitric oxide in the lungs. There's almost no systemic absorption, so you're not going to see a drop in blood pressure, which can be really harmful depending on the pathology the patient has going on. The best part about nitroglycerin is that it is rapidly available in just about every emergency department. That's a massive advantage over epoprostenol, over nitric oxide. If you decide that you need to give a pulmonary vasodilator and you're reaching for nitroglycerin, the dose is 5 milligrams every 5 minutes by nebulizer. Honestly, it's hard to get that much, 5 milligrams into the neb chamber, unless you've got the super concentrated nitroglycerin, which most of us don't have. So what I do is just fill the chamber and crank the flow to get as much of that nitroglycerin down into the lungs, converted to nitric oxide, and doing its job at pulmonary vasodilation. My standard approach is to grab the nitroglycerin, start that inhaled to get some nitric oxide into those lungs, get that pulmonary vasodilation going on. And I'm doing that while I'm waiting for epoprostenol to come from the pharmacy, or in that magical scenario where I can get nitric oxide to the bedside while I'm waiting to get nitric oxide there. Time is really critical. That nitroglycerin, always available. I can get it on the patient rapidly, start to drop those pulmonary pressures so that the patient can start to improve. Let's wrap this up with 3 big things that we have to remember. In patients with acute pulmonary hypertension from PE or acute worsening of their chronic pulmonary hypertension, we want to focus on ways to create some pulmonary vasodilation. We can start by reversing hypercarbia and hypoxemia, but remember, we don't want to intubate these patients. Non-invasive can be really useful here. Bilevel is my go-to, but you could also try high-flow nasal cannula as long as hypercarbia isn't the major issue. And then we want to get a direct pulmonary vasodilator on board. And while nitric oxide is the classic agent that we go for, it's usually not readily available. We can't get it to the patient's bedside fast. And so instead of that, we can use inhaled nitroglycerin, which is converted to nitric oxide. You're not going to get systemic effects, but you are going to get rapid pulmonary vasodilation.
Now, cancer is the number 1 cause of mortality in Canada, and great advances have been made over the last decade in treating these patients. I see patients in the ED who have been living with pancreatic cancer, for example, for like 5 or even 10 years. And when I started practicing, the prognosis for these patients would have been maybe a few months. But with these great advances, we need to be aware of the chemotherapy effects that can be life-threatening and present to the ED. So Brit Long now is going to give us a beautiful quick hit on Cytokine Release Syndrome. And before he does, I want you to think about what it is, how it presents, and how you might manage it in the ED.
Cancer therapies are always changing. Chemotherapeutic agents, radiation treatments, antibodies. But with these new therapies come some new complications. It's not just febrile neutropenia anymore. Walter Himmel touched on immune checkpoint inhibitors and their complications in Quick Hits episode 32. Today we're going to look at cytokine release syndrome. You may have also heard this called cytokine storm. Cytokine release syndrome is a severe inflammatory response. It all comes from a sudden, massive release of cytokines. Ultimately, the end result can be multi-organ dysfunction and even failure. There are several different triggers: monoclonal antibodies, haploidentical donor stem cell transplantation, non-protein cancer drugs, and more recently, really where we're going to see this, chimeric antigen receptor T-cell therapy, better known as CAR T-cell therapy. This therapy uses genetically modified T-cells to attack malignant cells. There are currently 6 different CAR T-cell therapies being used for cancers like ALL, CLL, non-Hodgkin's lymphoma, and multiple myeloma. We'll have a list in the show notes for the different therapies. Most of the time, the infusions are provided in the outpatient setting. Back to cytokine release syndrome. The key here is that this is a clinical diagnosis, but if you don't know about it, you won't be able to diagnose it. Cytokine release syndrome is one of the most severe adverse events from CAR T-cell therapy, and it's more common than you might think. It occurs in up to half of all patients who receive this therapy for ALL, but the specific numbers depend on the individual therapy and the cancer type. Symptoms range anywhere from a mild, flu-like illness, maybe some GI symptoms, all the way to shock with severe, life-threatening end organ injury like renal failure, DIC, or cardiac dysfunction. There is a grading system based on the degree of hypotension and hypoxia, but all patients need to have a fever of at least 38 degrees Celsius that's not due to another cause to make this diagnosis. Grade 1 is fever with constitutional symptoms like headache, myalgias, but there's no hypotension or hypoxia. Grade 2 is fever with hypotension, but this responds to fluids alone, or they need supplemental oxygen at less than 6 liters per minute. Grade 3 is fever with hypotension, and they need a vasopressor or they need supplemental oxygen of at least 6 or more liters per minute. Grade 4 is fever with hypotension that requires multiple vasopressors apart from vasopressin, or they need positive pressure ventilation or mechanical ventilation. Now, one of the major issues with this diagnosis is that all of these signs, all of the symptoms, they're really nonspecific. These patients will look just like sepsis or septic shock, or a PE, or CHF, or even tumor lysis syndrome. Your key is the history. If they present within 2 weeks of receiving CAR T-cell therapy and they have fever that's not due to another cause, plus they have constitutional symptoms or hypotension or hypoxia, you have the diagnosis. There is no one lab test or imaging modality that's going to definitively diagnose cytokine release syndrome in the ED setting. But you need to look for other complications, other conditions like sepsis or tumor lysis syndrome. Plus, you need to evaluate for end organ injury. You might find white blood cell count changes like leukocytosis, leukopenia, or neutropenia. Patients often have elevated serum creatinine or liver enzymes. There can also be coagulation abnormalities and electrolyte changes like hypokalemia and hyponatremia. Management is just like any other critically ill patient. You know what to do here when it comes to resuscitation: fluids, antipyretics, and they might need supplemental oxygen or vasopressors. You're targeting a systolic blood pressure of at least 90 and an oxygen saturation of at least 94%. If they're sick, definitely give them broad-spectrum antibiotics, and no matter the grade, make sure to consult their oncologist. They'll be able to help you with further treatments. If they're grade 1 and they improve with your treatments, they may still be able to receive CAR T-cell therapy. Patients with grade 2 or worse will need to stop their therapy, and they'll also need tocilizumab. This is an interleukin-6 antagonist. If they're grade 3 or worse, then you need to add steroids, something like hydrocortisone, dexamethasone, or methylprednisolone. In summary, cytokine release syndrome is a supraphysiologic inflammatory response with massive cytokine release. It's most commonly associated with CAR T-cell therapy. If the patient has a fever that's not due to another cause, plus they have constitutional symptoms or hypotension or hypoxia, and they've received CAR T-cell therapy within 2 weeks, it's cytokine release syndrome. Resuscitate and speak with their oncologist.
All right, I think I got this. So fever NYD plus CAR T therapy within a couple of weeks plus constitutional symptoms or hypotension or hypoxia is cytokine release syndrome until proven otherwise. And now a quick word from one of our sponsors, Northern Health. Looking for more than just a shift? What if your next move gave you adventure, balance, and a team that has your back? In Prince George, BC, Northern Health is hiring emergency physicians, physician assistants, and nurse practitioners to join a high-performance emergency department with over 54,000 visits a year, full specialist support, and a collaborative team environment. Think short commutes, affordable living, and world-class hiking, biking, and winter sports right outside your door at the center of the province. Flexible scheduling, competitive compensation, and real work-life balance included. Ready to make an impact and actually enjoy where you live? Visit careers.northernhealth.ca and join the emergency team in Prince George today. All right, let's switch gears now. Kids' bones can remodel remarkably well. And when we see a kitty with an angulated distal radius fracture, most of us just want to reduce that thing in the ED. It's so satisfying for us. The parents see the post-reduction x-ray and they feel relieved, and it's just a beautiful thing. Here's Andrew Tagg and his take on a Peds study that may give you some pause before you just jump in and reduce that Peds distal radius fracture.
This is Andy Tagg from Don't Forget the Bubbles, taking a look at the recent Craft trial. So let's start with the case. The 7-year-old falls off the monkey bars. They come in holding their wrist. You take a look, and it's clearly deformed. You give them some intranasal fentanyl, splint the wrist, and send them for x-ray. And when they come back, it looks wrong. Bent. The distal radius and arm are off-ended. It's the kind of image that makes everyone in the room instinctively think, we've got to do something about that. What if we didn't? Distal radius fractures are among the most common injuries we see in children, and for decades, when they looked grossly deformed, the default has been reduction, often under sedation or general anesthesia, and plus or minus fixation. Not necessarily because of strong evidence, but because the deformity looks just unacceptable. The Craft trial asks a simple question. Does fixing these fractures actually improve outcomes? So let's take a look at the details. This was a large, pragmatic, multi-center randomized trial across 49 hospitals in the UK. They enrolled 750 children between the ages of 4 and 10, all with severely displaced distal radius fractures. And they randomized them to one of two strategies: surgical reduction with or without fixation, or casting alone with no manipulation. The primary outcome was function at 3 months, measured using the PROMIS upper extremity score. And importantly, this was designed as a non-inferiority trial, with a margin set at minus 2.5 points. And that number matters. We'll come back to it in a minute. At 3 months, the surgical group did slightly better. The mean difference was minus 1.64 points, favoring surgery. And if you remember one number from this trial, it's that difference at 3 months was about 1.6 points, well below what families considered meaningful. It's also worth remembering that this wasn't a blinded trial, and the outcome was parent-reported, so that some of the early differences may reflect expectation as much as true functional benefit. So on the surface, surgery wins. This is where it gets more nuanced, because the confidence interval crossed the non-inferiority margin of minus 2.5, which means technically non-inferiority was not demonstrated. Now, if you stop there, you might conclude that casting isn't good enough. But that would be missing the point, because that margin, minus 2.5, was deliberately conservative, actually smaller than what we usually consider a clinically important difference, and smaller than what families in the study said would justify surgery in the first place. So that observed difference, minus 1.64, statistically awkward, but clinically, probably trivial. And then look what happens over time. By 6 months, there's no difference. By 12 months, still no difference. So whatever early advantage surgery provides, it doesn't last. Now let's think about what surgery actually adds. Well, in that early period, there were complications, infections, scarring, nerve irritation. Refractures were slightly more common in the casting group, but overall they were uncommon. And then there's the financial cost. Casting saved around £1,600 per patient, roughly 2,800 Canadian dollars. And that was with only a very small reduction in quality-adjusted life years and 100% probability of being cost-effective. So you're paying more and exposing the child to procedural risk for a benefit that disappears by 6 months. This is a good example of the gap between statistical thresholds and meaningful patient benefit. And it's worth saying this isn't coming out of nowhere. Dan Perry and his group have been consistently challenging some of the things we've been always done in pediatric orthopedics, including the FORCE trial, which we discussed in EM Quick Hit 68, asking whether less intervention might actually be enough. And underlying all this is a familiar tension, the difference between what looks wrong on an X-ray and what actually matters to the patient. Because when function is the same by 6 to 12 months, does raise the question whether we're sometimes treating the X-ray rather than the child. This trial applies most clearly to children between the ages of 4 and 10. And in younger children, you might expect even greater remodeling, and perhaps in older children less. It's also a pragmatic study. There was variation in how treatments were delivered and some crossover between the groups, but that probably reflects what actually happens in practice. Of course, this is one of those areas where local practice and orthopedic preference will still play a big role. So these conversations need to be collaborative rather than confrontational. So what does it mean in practice? Well, for children aged 4 to 10 with severely displaced distal radius fractures and no red flags, cast-first approach is a reasonable default, even when the fracture looks dramatic. But there are clear boundaries here. If the child has any neurovascular compromise, threatened skin, an open fracture, or you're dealing with an older child closer to skeletal maturity, this trial evidence doesn't apply. Reduction is still very much on the table. So, on my next shift, if I see a 7-year-old with a dramatically displaced wrist, but a normal neurovascular exam, I'm much more comfortable having a cast-first conversation with the family rather than assuming they need a trip to the theatre. And the next time you see an offended wrist and feel that pull to fix it, take a moment and ask yourself, what would happen if I did less?
A patient presents to the emergency department with bradycardia. What should you look for on the 12-lead ECG? Interestingly, ACLS provides no guidance. The adult bradycardia algorithm says 12-lead ECG, if available, don't delay therapy. So you can look at the 12-lead if you want, but this doesn't alter the ACLS algorithm, which is atropine, epi, or pacing if the patient is unstable, or monitor and observe if the patient is stable. There's a good reason why ACLS algorithms don't use 12-lead ECGs, because they are designed for primary arrhythmias caused by an intrinsic electrical problem in the heart and treated with medications or electricity to slow down or speed up the rate. Every ECG lead shows the same rhythm, so why bother with 12 leads when you already can see the rhythm on the rhythm strip or the cardiac monitor? ACLS provides a one-lead ECG interpretation for electrical problems to guide electrical solutions like pacing for bradycardia or cardioversion for tachycardia. This works great for primary arrhythmias, but many patients we see in the ED have arrhythmias from secondary causes, and this is where the full 12-lead ECG can make a difference, at least with some causes. A study on compromising bradycardia in the ED with a mean ventricular rate of 33 found that half of patients ultimately required a pacemaker, but the other half had a reversible cause. As the authors concluded, identification of treatable, reversible causes of the bradycardia is the key for successful management. ACLS does advise to identify the cause of the bradyarrhythmia, but there's no indication of how to do that or how the 12-lead ECG might help. So let's review the Brady mnemonic, which summarizes treatable, reversible causes of bradycardia and how we can complement ACLS with better history and ECG interpretation. B stands for Brash syndrome, which reminds us of hyperkalemia. Brash syndrome is a combination of bradycardia, renal failure, AV node blockade, shock, and hyperkalemia, which creates a vicious circle. Regardless of whether the full Brash syndrome is there or not, hyperkalemia is a critical reversible cause of bradycardia that will not respond to atropine or pacing. Hyperkalemia can produce sinus bradycardia, junctional bradycardia, or wide complex bradycardias, wide PR or QRS complexes, axis deviations, and diffuse peaked T waves. In a patient with a good pretest likelihood of hyperkalemia, like a history of chronic renal failure, presenting with vomiting, dehydration, and weakness, bradycardia and other ECG signs of hyperkalemia on the 12 lead can guide impaired calcium. R stands for reduced vital signs. Every bradycardic patient needs a full set of vitals and immediate treatment of hypoxia and hypoglycemia. But temperature is not always checked, so the 12-lead ECG might show signs of hypothermia, including bradycardia, shiver artifact, wide QRS and QT intervals, and prominent J waves. A stands for acute coronary occlusion. The left circumflex perfuses the SA node as well as the lateral and posterior territories, while the RCA perfuses both the SA and the AV nodes as well as the inferior and posterior territories. So if a patient has bradycardia in the context of chest pain or other symptoms of ACS, the 12-lead ECG might show inferior ST elevation or hyperacute T waves, reciprocal change in AVL, or anterior ST depression reciprocal to posterior ST elevation. D stands for drugs, including beta blockers, calcium channel blockers, DIG, or opioids. Intentional or accidental overdoses or accumulation of drugs from renal failure can lead to bradycardia. This may require reversal, like calcium for calcium channel blockers, or just simply holding the medication and letting the patient clear it out of their system. Most of these cannot be identified by ECG, though DIG may cause a short QT and scooped ST depression. I stands for intracranial pressure or infection. Elevated ICP should be suspected clinically, for example with a headache and lethargy, but the ECG may show so-called cerebral T waves, which are diffuse and deeply inverted T waves, along with a long QT. Most infections don't cause bradycardia, but Lyme carditis causes AV block, including third-degree AV block that is reversible and can save the patient from a permanent pacemaker. So if your patient is bradycardic, ACLS provides a good initial approach to stabilization, but you should also ask yourself, why is this patient brady, including brash or hyperkalemia requiring calcium, reduced vitals requiring oxygen or warming, acute coronary occlusion requiring reperfusion, drug toxicity requiring reversal, or ICP or infections like Lyme carditis requiring treatment. This can help identify reversible causes of bradycardia and the role of the 12-lead ECG, especially for hyperkalemia and acute coronary occlusion.
In case you haven't heard yet, tickets for the next virtual EM Cases Summit just went on sale July 14th at emcasessummit.com. Please join us November 21st, 22nd, and 23rd for 3 days of the best EM Cases speakers from around the world, state-of-the-art procedural demonstrations, expert panel discussions, rural EM sessions, prize giveaways, simulations, and fully accredited CME. It's also a great opportunity to connect with emergency clinicians from around the globe. And if you've been enjoying EM Cases for free over the years, attending the EM Cases Summit is one of the best ways you can support our mission and help us continue producing free podcasts, blogs, videos, and educational resources. Hope to see you all there. Visit emcasessummit.com for all the details. And now for the best of University of Toronto emergency medicine.
It's midnight, and you're heading into a night shift. The waiting room is full, and the hallways are lined with stretchers, a sea of patients waiting to be seen. As soon as you check in, your pager goes off for an incoming level 1 trauma. It's a pregnant patient at 32 weeks gestational age, involved in a high-weight speed motor vehicle collision. Unstable pelvis, unstable vitals. ETA, 10 minutes. You feel your heart rate pick up, and you think to yourself, it's going to be one of those nights. Hello, EM Cases listeners, and welcome to part 2 of our series on coaching the EM mind, critical skills for career longevity and joy, with guest expert Dr. Sara Gray. Last time in part 1, we covered strategies for addressing our physiologic needs to help us perform better on shift and preserve our health outside of work. In part 2, we'll be touching on issues of stress management and safety. We're going to explore key strategies on how to ground ourselves and keep our emotions in check when faced with high-stress moments on shift, how to diffuse tense encounters and prevent conflict from escalating, and how to effectively raise our concerns when we witness safety issues happening in real time. To answer these questions and more, we've got Dr. Sara Gray back on the podcast. Welcome back, Sara.
Hi, Katie. Thanks for having me.
Let's come back to that incoming level 1 trauma I mentioned at the start of the episode, our critically ill pregnant polytrauma patient. EMS patches at 5 minutes out with an update. Our patient is now in cardiac arrest, CPR in progress. Anyone else feeling the stress kick up a notch? We throw out all kinds of words to describe our emotional experiences, and I think it's important that we're all on the same page with the language we use as we talk about them. Sara, I want to start by asking, what is stress, and what's the difference between stress versus burnout?
Okay, great question. Stress is the short-term reaction to the challenge that you're facing. So like the maternal cardiac arrest that's coming in that I think we would all find stressful. We have a natural physiologic response to this type of pressure. This is a temporary thing, but it increases our energy levels, our epinephrine and dopamine go up. This helps us focus on finding solutions. And being stressed might still feel challenging, but typically solutions feel possible. Burnout is a much more chronic condition. So this is a state of exhaustion. It includes depersonalization, that feeling like you just don't care about the outcome anymore. It includes cynicism. And so burnout arises when we've had prolonged periods of stress or distress, not a one case situation, but a multi-day, week, month situation. And when we experience burnout, we get so overwhelmed that our overall energy levels go down. We get less motivated for all activities in our life. We start detaching from activities we used to care about. We start getting to that stage where we don't feel we care enough to work on solutions. And so burnout really comes with a sense of overwhelm and futility. And so in short, when you're stressed, your battery is running low, but a weekend off is going to fix you. When you're burnt out, your battery feels like it completely died 2 months ago and it's been run over a few times since then, right? Like a weekend is nowhere close to turning that around. So they are on a spectrum, but burnout is the much worse chronic version.
You, myself, and Anton, we've all chatted before about how it can be a good thing to be a little bit nervous before a high-stakes moment, whether that's running a resuscitation or potentially giving a talk at a conference. It can add that boost of energy and clarity that helps us perform well. But we've all probably also had moments where the stress goes too far and starts to become overwhelming, and that's when the wheels really start to fall off. Sara, how does stress impact our performance, and how can we titrate our stress levels so that it's in that useful zone and not that danger zone?
Yeah, you're absolutely right, Katie, that a moderate amount of stress does boost performance. And most people think about that bell curve picture of the Yerkes-Dodson law. Maybe we can put an image of that in the show notes. But we know that, say your stress level is very, very low, this is actually terrible for performance. This is where we're sleepy, we're drowsy, we're catatonic. We don't optimally perform in that circumstance. Moderate stress does give us that energy boost and clarity we're looking for. But then severe stress moves us into panic, overwhelm, shaking. That also deteriorates our performance. And so when you're thinking about optimizing your stress management, the goal here is not to eliminate stress. That's not possible. Life comes with stress, particularly when you work in the emergency department. But even if you work somewhere quite benign, life just comes with stress. This is normal. And so you want strategies to help manage your stress so you stay in that optimal performance zone. And this tends to fall into two big categories. Number one is those short-term strategies for the heat of the moment, right? Whether that's on shift or in the middle of conflict with your toddler, those are the short-term things you can do to manage your stress. And then long-term strategies for stress reduction is the second big category. And we talked about some of those in the previous episode. We talked about getting enough sleep, regular exercise, nutrition. Those all help modulate our stress response. But there are also other strategies that we can talk about today.
I often find that when I'm in the middle of a stressful moment or a particularly stressful period, I'm so deep in survival mode that I don't even recognize that the stress is necessarily happening in the background. It's usually the people around me who first notice those signs and then point it out to me. And then once it's identified, I can utilize my strategies, dig myself back out of that hole. But there's not much I can do if I'm not even aware that it's happening in the first place. Sara, do you have any strategies to help recognize when our brains have entered that high stress overload state, preferably before we snap at someone without meaning to?
Yeah, I mean, we won't fix a problem until we know we have a problem, right? So identifying it is key. And I will say my biggest wake-up call is when I raise my voice to somebody or I snap at somebody. And I mean, unfortunately, particularly this would happen at home too, like this would happen with my children. And often we'll find it's more likely to happen at home than when we're in a professional circumstance where we are better trained to hold it together. So if I ever snapped at my kids, I would know I was not okay and that I needed to actively regroup. You know, when your kids are little and they're misbehaving, so you put them in timeout, like you put them in the quiet corner for a minute or whatever it is. We actually had a system where my kids could put me in timeout, where they'd be like, Mom, no, you're not okay. You need a timeout. And they'd send me to my room for 5 minutes, which was actually extremely helpful because it would give me a reset. So, you know, if you have young kids as a strategy. But you do want to watch out for those other signs that you are in that high stress or overwhelmed zone. And so I look for changes in basics of physiology. Is there a change in your sleep? Is there a change in your diet? Are you skipping workouts at the gym? Are you skipping activities you normally love because other things are getting in the way? Right? And this happens to all of us. No shame, no blame here, right? Life is real and sometimes things happen. But when you start to notice you are out of your normal healthy pattern, that's when you want to think hard about what do I need to do to reset to help optimize how I'm coping here?
I think that's such an important point about that stress bleeding into our personal lives. And often we can kind of keep it under wraps until that shift ends and until we get home and suddenly we are letting our guard down and it starts to unleash itself in those ways. So paying attention to those cues is so important. I also find on shift, for me personally, my overwhelm I've recognized is when I start to have that indecision, when decisions become harder, when I feel like I just have no more bandwidth to take on even another single decision about another case or another complication around one that I'm already managing, that lack of bandwidth that I really, really feel in decision making. And now that we've recognized that our minds have entered that stress danger zone, what can we do about it in the moment? I want to come back to those in the moment strategies. Do we scream? Do we pull our hair out? Do we stuff our faces with emergency scrub pocket chocolate that we keep on hand for these sorts of moments?
Yeah, so let's talk about strategies for when we're on shift. And I've got 4 moves that I commonly do when I know that I'm overwhelmed or stressed or having that, I also get that where you're looking at the board and you just feel overwhelmed. You're like, oh, I don't even know who to reassess first. So number 1, take a break. And this can even be a 1-minute break. If you need to go hide in the bathroom for 1 minute, you can do that. It gives you a quiet space. You give yourself that baby time out just to reset, just to get a drink of water if you can. But we know breaks are actually really valuable for cognitive performance and for reducing stress. And so I know you can't always go take a 20-minute break, but even a 1-minute break can be helpful. So that's idea number 1. Idea number 2 is to get good at a breathing exercise. And there are all sorts of different breathing exercises out there. This is a really well-known stress reduction technique. And there are a few possibilities. One of the common ones is to do what's called box breathing. So and there are graphics for this. It looks like a box and you inhale for 4 seconds, you hold for 4 seconds, you exhale for 4 seconds, you hold for 4 seconds. And you sort of go around that visual of a square. And as you're focusing on your breathing, you can stimulate or induce a relaxation response in your body that helps lower your cortisol and your stress. And box breathing is only one example. You can do 4-7-8 breathing. You can do, there are all sorts of different possibilities here. The thing about them is, you need to practice them regularly. When I first started doing these, it would take a minute or two of doing a breathing exercise to really induce a good relaxation response in my body. But we are Pavlovian creatures. The more you practice this, the faster you can induce that response. So now I can take 2 breaths and get myself there. Like I can do it in less than 10 seconds. But only because I do it all the time. So that regular practice piece is key for these breathing exercises. If you do it as a one-off in the heat of the moment, I don't think you're going to find it all that valuable. Option number 3 for stress reduction in the moment is to do what's called a grounding exercise. So grounding exercises are things you can do, and there's a whole variety here. I'll give you a couple options. But these exercises make you feel more connected to the present moment, to make you feel stable or calm rather than overwhelmed. And so this is a version of mindfulness or present moment awareness that can help you manage strong emotions like stress or anxiety. Let me give you an example so you know what I'm talking about. My most common example that I do at work is I plant my feet on the floor really intentionally. And so maybe we can, people can do this right now. If you're sitting down wherever you are or standing, just push your feet into the floor a little bit, like intentionally put all of your weight into your feet. Feel your toes on the ground, feel the heel on the ground, contract those leg muscles. Okay, and then you're done. So it takes 5 seconds or whatever. But this is just letting you focus on the stability in your body. It connects you to the ground. It makes you feel physically stable. And if you do it regularly, just like the breathing exercises, you have to do it regularly. But doing this regularly helps us improve emotional regulation, helps us reduce those strong emotions just by focusing deeply on our present awareness. So you can ground with your feet, and that's really common because you can do that standing or sitting. The other one I do a lot at work is I will intentionally clasp my fingers together or clasp my hands together and squeeze a little bit, which puts my attention into my hands or fingers. And I will often do this during a difficult conversation or a stressful interaction. You can do it nobody knows when you're doing this, right? My patients don't realize, nor would a colleague or anybody else, but it helps you stay centered. And part of what I'm doing when I squeeze my fingers together or my hands together is I can feel my wedding ring when I do that, which is a really important talisman for me and just subtly reminds me of what is important in my life and who I am. And that subtle reminder helps me stay grounded. And so, again, you can pick what type of grounding exercise works for you. If that, is interesting to you, an easy Google will find you 50 variations on this theme. But these are all very brief present moment practices to help us stay centered. And then idea number 4, the last idea that I would raise for people that helps us manage stress and helps optimize performance is to develop a version of positive self-talk. And this is a brief phrase you say to yourself. You don't have to say it out loud. You can say it in your head. Nobody has to know you're talking to yourself. But it helps improve confidence and actually helps us perform better. So this is a concept that was popularized by Olympic athletes. Laurie Hernandez was a U.S. Olympic gymnast who went on to win gold. And she wrote a book about this. Her phrase that she uses was, "I've got this." And she would say it to herself before every performance. And you can see her when she performs saying it to herself because we know it improves confidence and improves performance. It helps counteract that stress we feel in the heat of the moment. So developing a phrase that works for you can be really valuable for when you're walking into that stressful resuscitation, that stressful conversation. And it's usually something very quick. You say it to yourself inside your head. It maybe takes a second or two, but having a phrase like, "I've got this. We can do this. I'm on it. I'm ready." Whatever that might be, you want to find a phrase that resonates for you, that sort of works for you and your personality. I usually go with sarcasm because that's a good personality match for me.
Now I really want to hear what your phrase is.
Oh yeah, no, I can't tell you. It'd be too embarrassing. But having something like that is actually well described as a good stress management technique to help us optimize performance in the heat of the moment. I figure if Olympians are doing it, it's probably a good idea for us too.
I completely agree. Fantastic strategies. Just to recap, are 4 strategies that we've just talked about. Number 1, take that break, that time out to reset. Number 2, use a breathing exercise to ground your physiology and ground your mind, whether that's box breathing or one of the other breathing strategies. Number 3, a specific grounding exercise like planting your feet on the ground or clasping your hands together and squeezing, something subtle. You can find something that works for you and can be very, very quick to implement in the moment. And number 4, cultivating that positive self-talk. My own personal one is, you can do hard things. I tell myself that over and over. It started when I was training for a half marathon and has just continued on since then. But I want to come back to something that you said before, which is the idea that our tools are only as good as our practice of them. You know, if we don't sharpen our tools before they're needed, they're not going to be ready for us when we actually do need to reach for them. We would never expect to be able to perform an emergency crike without ever having thought about or practiced it before. So why do we expect mindfulness tools to work perfectly in the heat of a stressful moment when we've never spent time practicing them beforehand? And Sara, I'm really curious about, asking for a friend and also for a whole audience of listeners. If you were to advise someone who was new to mindfulness practices, what are some easy ways to actually get started and to implement them successfully?
It's a good question, Katie. For me, I did not find it easy to get into mindfulness practices at all. So maybe I'll tell you a super quick story about that in case it resonates for anybody in the audience. So I grew up in one of those households where we were not big believers in things like mindfulness or meditation. We thought that was kind of hokey bullshit for other people. So I was raised with a lot of skepticism around this, maybe frank cynicism around this. And then it was probably about 20 years ago now, someone bet me that I couldn't sit still with my eyes closed for 5 minutes. And they bet me $50. And I love a challenge. I'm really pretty competitive. So of course I said yes. And I took the bet. And then much to my horror, I lost. I failed hard. I sat still for about 90 seconds and then I had to move and open my eyes. So I had to pay them the $50. And I don't like losing at anything. And so I immediately decided that I needed to master meditation, and not because I thought it would be helpful for me in any way, but because I generally refuse to fail. And so I signed up for one of these mindfulness-based stress reduction courses. And for those who are not familiar, this is like one of those 8-week courses where you commit to meditating 45 minutes a day for 8 weeks. And Katie, oh my God, it was so hard for me. Like, this might be actually the hardest thing I've ever done. It was brutal, but I got better at it. I mean, anything you practice hard, you will improve at. And by the end, I could sit for 45 minutes and concentrate, which was kind of cool. But I still didn't think that meditation was intrinsically valuable for me or useful. I honestly just wanted to win the next bet. And it was near the end of the course that my husband was like, who's also, frankly, a mindfulness skeptic. He was like, honey, you have to keep meditating. And I was like, what do you mean? What are you talking about? He was like, you are a completely different person. He's like, you are calmer, you are kinder, you are funnier. And I was like, oh, like, maybe this actually is a valuable thing for me. So I don't know. I still have some of the meditation skepticism I was raised with. I don't know how meditation works. I don't know why it works for me. But I swear, Katie, I am a better version of myself when I'm meditating. And that's what keeps me coming back to it. There are easier ways than signing up for the massive course. Like, there are lots of great apps out there. There are videos about this. There are podcasts if you want to go that way.
I love that your strategy was to jump right into the deep end with an 8-week course, Sara. And so you mentioned some of these other strategies to ease into maybe the shallow end a little bit more gently for people who want to try it. What are your thoughts on things like guided meditations or even just implementing some of those breathing and grounding exercises, just 10 seconds a day, 1 minute a day, implementing those on a more regular basis so you can start to build up those muscles?
Yeah. So there are, I love all of those ideas, Katie. There are lots of great apps out there, like, and I have no affiliation with any of these, but like Calm or like 10% Happier or Insight Timer, lots of great guided meditations. And you can find really short ones if you want to start short, right? There is data that just 1 minute of meditation a day improves emotional regulation and reduces stress. So it doesn't have to be for a long period. Or you could just start a breathing exercise. And if I was going to do that, I would Google a few of the options, pick whichever seems awesome to you, because I don't know of any data suggesting that one exercise is better than another. And then practice it for 2 minutes a day until you get good at inducing that stress, relaxation response that you're looking for. And then once you're good at it at home in sort of a quiet environment, then you can start bringing it to work and practicing it there. And we can talk about that.
You heard it here, EM Cases listeners, 1 minute a day. And then you've got a tool that you can use the next time you're walking into a big stressful recess. So let's come back to our big stressful recess that we were talking about before, that level 1 polytrauma pregnant patient. Sara, when you have the time to anticipate a potentially stressful upcoming encounter, like our upcoming resuscitation case, how do you effectively prime or prep yourself and your team in advance?
So as I'm walking down the hall to the resuscitation, I am doing my breathing exercise on the way. I do it every time. Yeah, I can do it while I'm walking. You breathe while you walk anyway. I walk, I don't run, right? No running, because we want to arrive calm. When I get there, as I'm walking into the room, I say my positive self-talk phrase to myself. And then once I'm in the room, I'm going to ground my feet while I have a pre-brief with the team. Pre-briefing is really helpful because this is where you're making a plan. That helps us focus. Having a plan in itself helps reduce our stress. And while I'm doing that pre-brief, I do have my feet grounded, or some people like to stand in that superhero pose, that was popularized on Grey's Anatomy so many years ago. That confident body language helps us feel more confident and also helps inspire our team to feel confident. And then the other thing to think about is you can also use positive self-talk as a group, right? You can boost the confidence of your team by saying, "We've got this," or "Let's do our best," or "We are well trained for this, let's go," or whatever phrase seems natural to you. But positive self-talk can be used in a group setting, not just for individuals.
This reminds me a little bit of when I was a medical student watching the old ER for the first time. I remember an episode where Dr. Green, is having to run a big resuscitation, and the chief says to him, "You set the tone, right? You set the tone as the team leader. And when you set the tone well, and when you set the tone calmly, and when you set the tone for success, it helps the rest of your team feel ready to tackle that case to the best of their ability." So we set the tone. And sometimes slow is smooth and smooth is fast, as you mentioned. I love those suggestions. We've talked about those big stressful moments, like the incoming maternal cardiac arrest polytrauma case, but there are also those less obvious stressful moments on the job as well. An angry patient or family member, a verbally aggressive consultant, or even that feeling of an overcrowded department with too few staff and too few beds. It's really easy for tempers to run hot in that setting. Sara, during those high stress or emotionally charged encounters with patients or consultants or other colleagues even, what are some common mistakes to avoid and some tips to de-escalate or diffuse the tension in the room?
So the big mistake here is to add more stress or emotion to the encounter. You really want to focus on diffusing as much as possible. So let's talk about some strategies for lowering emotional heat. Number 1, you just want to slow it down. When we are talking fast, we talk louder, emotions rise. So you want to talk a little slower, a little lower. You want to take a deep breath. If you take a deep breath, the other people in the room are more likely to take a deep breath also, just because that's a behavior we tend to mimic. It's very primal physiology, but that also just lets everybody breathe for a second, helps us take that pause and try to get our frontal lobes back online. You can still do grounding here, which we talked about, right? Useful in resuscitation, but also in difficult conversations. The next thing I try to think about, particularly if it's really emotional, is it can be useful to name the dynamic in the room and to validate that. And it helps people identify how they're feeling and regroup a little bit. So if I sense my patient is frustrated, I'll often say, I see that you feel frustrated. Is that right? And I let them identify that emotion. And that in itself often really diffuses the power of what they're feeling. And once they've named it and identified it, or we've validated it, it helps us move past that and on to problem solving. This is the same if you're running a resuscitation and it's getting very stressful in the room. It can be really valuable to say, wow, this room is, I'm feeling stress in the room. Can everybody just take a breath for a second? We're going to refocus on our priorities. Calling that out actually helps diffuse it rather than increase it. So that's a useful strategy. My next thought when we're trying to de-escalate is, can we reorient around our goals? And this for me often happens when you're having that difficult conversation or there's a disagreement, often with consultants on the phone. If we can realign around our common goals, our common objectives, we can find some alignment that helps us work together more effectively. And this is always like all healthcare providers want the patient to have a good outcome. We all want that. No matter what, service you're on, we all, none of us wish harm to anybody. And so often on the phone, if we're having a difficult conversation, I'll say, hey, I know we both want this patient to have a good outcome or the best outcome possible. How can we work together to make that happen? Right? So talking out loud about what our common goals are can be useful. This works also with patients. If they're, have a concern aligning around what they want, we both want you to have the best possible outcome today. We both want you to have the best healthcare available to us today. Let's work together on that. And that alignment can often, again, help reduce that emotional tone and help you get back into a constructive conversation. And I guess the last pitfall I would mention just to avoid is no personal attacks ever. No saying you did this or you did that. It's never constructive. I always focus on plural pronouns, on what we can do together, how we can be on the same team. That keeps me moving in the right direction.
I think that's a great framework to just bring that tension in the room down a notch and get back to something a bit more productive and move forward from a scenario. So just to recap, number one, we start with ourselves. We start with making sure that we are a calm place that we can come from as we're problem solving. Number two, naming the dynamic in the room and validating it to help everyone recognize what's going on so that we can pivot and move forward. Number three, reorienting around those shared goals, just to help bring it back from you versus me back to we. And finally, avoiding that personalization of the situation, really focusing on the scenario and the problem at hand. How can we fix this together rather than attacking the other person at the other end of the interaction? Fantastic approach to de-escalating that tension. Sometimes it can be difficult to speak up when things get heated, even to bring anything up at all, especially when there is a power dynamic in the room or if there's really strong egos at play. And even if we notice safety concerns or errors that are happening in real time, it can be really tough to bring that up in the moment. So the medical legal world is full of cases that ended in tragic outcomes because someone failed to listen or someone didn't feel comfortable raising a concern even as they saw it happening. Sara, any suggestions on what language we can use effectively to speak up in real time if we see something actively dangerous, especially when there are challenging dynamics or egos in the room?
Yeah, it can be tricky, right? When we have lots of people in the room. I prefer to use the safety escalation language that I think we stole from the field of aviation, where we use a 4-part structure and each of the phrases sort of increases your level of concern. So I'll tell you the structure first and then I'll give you an example. So you start by saying, I notice, and you make an observation of the thing you're worried about. The next one is, I wonder, where you give a suggestion of how it could change. If there's still nobody responding to your concerns, you say, I am worried, and you identify your worry. And last but not least, you say, this is now a safety concern, or we have a clear safety concern. I am now going to do this. And you sort of become declarative. And so I love just the first part of that, the I notice phrase. Like you could say, I notice the SAT is 82. And hopefully then somebody's going to take action on that. And that's enough of a prompt, right? But if not, if you need to escalate, you say, I wonder if we could switch this patient on to a non-rebreather or whatever that might be. And if nobody's still doing anything about the hypoxia, you could say, I am worried this patient is critically hypoxic. Maybe we need to think about intubation. And if still we're not making progress, you say, hey, this is now a safety concern. I'm going to take over the airway and intubate. And so that's sort of a classic progression where you start by just your observation, and then you add, I wonder with an option, I'm worried. And then at the end, if you have to, you do just take charge.
The idea that we are giving the benefit of the doubt to the other person, the rest of the team, maybe they're just tunnel visioned because there's so much going on. They didn't actually see the SATs because there's a million other beeping monitors happening. And you give that chance for the whole team to reorient again around that shared goal. But you escalate over time to ensure that the right thing happens in a timely fashion. So that safety escalation language, again, I notice, I wonder, I'm worried, and this is now a safety concern I'm taking over. I know from personal experience that the impact from these high stress encounters can extend beyond the case or even the shift itself. I still remember my first pediatric resuscitation as a resident, and years later when I think about that case, I can still picture the exact sights, sounds, and emotions as if I was reliving them all over again. So I want to take a moment to touch on post-event recovery techniques, how we can reduce the long-term impacts of experiencing these moments. We spend a lot of time training to be excellent resuscitationists, but we don't spend much time, if any, training for the aftermath. Sara, after a high-stress encounter is over, what can we do immediately afterwards to increase some of that separation between what just happened and everything that comes after? How do we recover and continue on with our shifts?
So there are a number of strategies here that are really important because I think this is a common thing that happens to us on shift. So my favorite recovery technique is debriefing. This could be with your whole team. It could be with a trusted friend or colleague. And there are a variety of different debriefing models you could use. But this is an opportunity to discuss what happened. It's an opportunity to deal with some of the questions that may have arisen or some of the emotions you're feeling around it. And certainly if a resuscitation has a lot of emotional residents, you can arrange to have a cold debrief the following week or check-ins or peer support if that's available in your place. But even just taking 5 or 10 minutes to talk about it, because I know time is short on shift, but those 5 minutes can really help me go back to my next patients with a much more reasonable mindset than if I try to jump straight back in while most of my brain is still processing that difficult case that happened. So debriefing is my top tip. Number 2, if you're not in the place or you don't have a moment to debrief, just take a quick break to decompress on your own. 2 minutes to get a glass of water and get a snack. This can save the rest of your shift. And you can use that time to think about the case and to acknowledge how you feel, acknowledge what went well. But just taking those 2 minutes can help you get some bandwidth back. depending on your work situation, there are definitely days where my recovery needs to include a hug. So strategy number 3 might be just find a friend and get a hug, particularly if you're a physical touch person. Sometimes this is more valuable than talking about it. So that depends on what you personally find comforting and soothing. But a hug can be just as good as a debrief. My 4th point, the last thing I would ask people to consider is, do you just need to stop working that day? Like activate your second call or call for help or get somebody to cover. Like some situations are so dire that I think we should not go back to work afterwards. And it's really useful if your department has policies around this or guidance already in place. Like, for example, I think that if you get physically assaulted on shift, you should not keep working after that. That's my personal opinion. But I think having policies in place around that or having a group understanding around that can be really valuable, just so that people aren't going back to work in situations that are actually potentially unsafe for them or their patients.
I think that's such an important consideration. And it's so hard, I think, for us to acknowledge sometimes that it is a situation where we maybe should reach out to our leadership teams, reach out to enact some of those policies, because it is not a safe space for us to continue on with that shift, either for ourselves, the people around us, the patients that come later in the shift. It's not the right thing to do. And that having those policies to protect that ability to walk away when we need to, I think is really key. Let's extend this discussion to routine end-of-shift strategies that prevent work stress from coming home with us on a regular basis. Do you have any end-of-shift routines that you use to help prevent things from crossing over into your personal life?
Yeah. During COVID, we had this poster up in our locker room that I really liked. And on the poster, it prompted you to list 3 things that you did well that day. Because naturally humans have a tendency to focus on the negative. And so intentionally spending a little bit of time considering your positive impact can help us feel a lot more satisfied with our workday, no matter what happened that day. So I still have that practice of trying to identify 3 things that I did well, even if they're tiny, even if the rest of the day was a disaster. It helps me feel a little bit better. And then I'm pretty intentional about how I use the drive home. I have music that I like that sometimes I'll play. I have podcasts that I like. I am looking for that drive home to be something that feels soothing and supportive to me. So I won't listen to anything super polarizing. I also keep food and water in my car 24/7, so I never arrive home hangry. And I have made a personal commitment to myself that I will stay in my car until I can walk into my house and show up for my family the way I want to. And this means sometimes I have to park down the street and stay there for a bit until I can get my head on straight. If the shift is really bad, sometimes I call one of my failure friends to talk it over.
On the flip side, do you have any pre-shift routines that help to reduce the personal stressors from affecting your work on shift? Because sometimes our personal lives are particularly chaotic or stressful.
Yeah, I have a whole pre-shift routine. So I listen to something medical on the way there in the car or on my commute. It helps me get my brain into work mode. I like to show up a little early. Mostly because if I show up late or I'm rushing, I don't show up with my best mindset. When I'm getting changed, I have a Post-it note in my locker. It's stuck on my locker door and it has the reasons like why I love my job, about why my work matters to me. And I read those notes before every shift, actually, just to get me in that mindset. And then I usually, then I get my coffee because we've talked about my caffeine addiction and I go in. And so that works for me. I know lots of colleagues who have like a specific walk-on song that they like they'll play some great music. And so I know like many variations on the theme of having that routine, but I think developing it is actually really valuable. I love having a routine before shift.
I would agree. I have this 2-minute YouTube video that's like this motivational athletic sort of video called Get in the Grind, about waking up and getting into it and doing those hard things because they are at the end of the day worth it. And I actually send it to all of our residents about a week before they write their Royal College exams, just because I find it has been so helpful for setting that mindset, especially before a tough shift. Beyond the individual level, what are some of the existing departmental or hospital-based policies that can reduce overall stress and increase safety in the EM workplace?
Great question, because there are things we should be expecting from our emergency medicine leadership. Number one, I think all of the staff in the emergency department should get formal training in de-escalation. And this should not be a one-off that you do once in your career. This should be a regular thing. And it should be interprofessional. This should also be the nurses are getting trained, security's getting trained, but we should have formal training available to us for how to do that. Number two, we should also have formal debrief training on how to lead debriefs, both hot debriefs and cold debriefs, because there are a whole different number of ways to do that. I also think this should be interprofessional. It doesn't always have to be the physicians who are leading a debrief. Our charge nurses can certainly do that, and we train with them at my place on how to lead this effectively. But you need to have a cohort of people trained who can lead debriefs if you want to embed it in your culture. And so I think leadership should be investing in that training to keep workers safer. I also think hospitals need to have some of the policies we've talked about, policies around what to do after somebody has been physically assaulted on shift, or even verbally or emotionally assaulted. Policies around, can you get time off? What are the modifications for coming back to work after you've experienced a significant event? And my last tip from a system perspective would be that I really love when we have a peer support program in place. People can reach out to get peer support after they've had a difficult case or a safety incident. And this just helps normalize the fact that we should look after each other, that we are all on the same team, and that we can provide that support and that understanding that we need as colleagues to make sure that staff are really supported psychologically in the way that we need to show up at our best.
There you have it, folks. Some practical pearls for meeting our stress and safety needs on and off shift from Dr. Sara Gray. Remember, even during the most chaotic of times, taking a few seconds to ground ourselves can help us better meet the demands of those high stress moments. As the U.S. Navy SEAL motto goes, slow is smooth and smooth is fast. Take those 10 seconds because they could make all the difference. Find ways to pause, reset, and reframe before, during, and after high stress encounters. It can help reduce the negative impacts of these events in the long run and prevent cross-contamination of stress between work and personal life. Take the time to check on your colleagues. You never know who might be struggling, and when that moment of compassion makes all the difference. It's been a lifeline for me on many occasions. And finally, tools are most useful when we practice with them and use them regularly. This includes mindfulness strategies like grounding exercises, breathing exercises, and the language we choose for de-escalation and conflict management. So practice intentionally and often. Sara, any final words of wisdom to add for our audience?
Well, I think when I look back over, I've been working in emergency medicine for a little over 20 years now. Oh my God. But I do think the single biggest modifier of my stress levels has been my mindfulness practice. That was really where I learned to use my breathing to control stress, how to focus, how to concentrate on the present moment. Like those attentional skills have been really valuable for me. So even if you are a skeptic like me, maybe check it out. It was absolutely a game changer for me.
I think the results speak for themselves, Sara, truly.
Oh, thank you.
And that brings us to the end of part 2 for our Coaching the EM Mind series. I'll catch you next time on part 3, where we tackle the topic of operating in teams, breaking down silos, and cultivating strong support networks on the front lines. As we wrap up, once again, here's my challenge to you. What is one thing you're going to do differently to help keep yourself safe and stress optimized on your next shift? Thanks for listening, and remember, you are what you practice, so make it count.